Hey, good evening, folks. John Matus here again. Um, Wanted to do a piece on disinfection today. I'm damn near exhausted. Put in a pretty full shift today. Came back, did a bunch of sort of administrative stuff here on my laptop, and like running on like 18 hours now. But I wanted to get this piece done because trying to keep on a certain amount of content, and honestly, things are kind of heating up here in New Jersey, so I wanted to talk to you a little bit about some of my concerns as they're related to just staying out of trouble and disinfecting and making sure that you're kind of adequately shedding the virus off of you and making sure you're not dragging it home and making yourself sick. So, like always, wanted to start with some basics here. You kind of know my rating system if you've seen the videos before, but if I feel it's pretty evidence-based and it's got some reasonable data behind it, 3 thumbs up. Some evidence behind it, 2 thumbs up. If it's anecdotal and I feel like it's just a one report or a video or something kind of, not super substantial, 1 thumb up. And if I feel like there's like no data to support it at all, it gets a crazy tinfoil hat lady. I promise there'll be some of those soon. Here are the numbers for today. Split's still about the same. Over 1 million cases now worldwide, plus the ones we don't know about. Remember, China is reporting crap, and they probably have just hundreds of thousands of unknown cases. And to be fair, so does the rest of the world. Nobody's able to keep up with testing. There's a few holdouts that are doing a pretty good job, South Korea, Hong Kong, but Taiwan. But I would say most of the rest of the world is probably grossly underestimating because they simply can't test fast enough. So between not having enough tests, not deploying them correctly, which was the US story, and the idea of mild illness never reporting for treatment, there's probably a lot more than that going on. But there's, again, over 1 million. I think this pushes almost 1,100,000. Not quite there, but somewhere in the ballpark. Deaths are still hyperinflated again because of the mild illness that's lost. So you could look at those numbers, and they're probably okay, but don't run around with a 20% fatality rate because it's nowhere near accurate. I gotta be honest, I've run a little numb to this. This was at one point in time one of the things that I looked at every single day to see developments, and the numbers now are so large that I hate to say it, but it's just really hard to derive any info. You can look for patterns, and that's useful. Like we know China's full of crap. In a country of 1.5 billion people, I doubt 35 is a realistic daily update, plus or minus. I mean, 35 just seems too small for everything. Their deaths per 1 million populations feels a little light to me also. I mean, the containment would have to be so aggressive and so effective for this to occur that it's really hard to imagine. And don't get me wrong, they have a lot of leverage being an authoritarian country. I mean, they could really put a smackdown on their people, but it's still a little hard to imagine that they were so effective that they just stamped it out. I mean, it's just, I don't know. Even in influenza in a country like that, you would see a lot more than 35 cases, and influenza is harder to catch. So it just doesn't feel believable. So a couple of other little patterns, again, Italy and Spain, the hot pots there of Europe, producing some pretty incredible figures. Here in the United States, we've transitioned into 5-digit increases pretty handily. As you can see, there are almost 30,000 cases, and you're starting to see it on the streets. Maybe it hasn't hit your neck of the woods if you're in the U.S., but we've got a lot of areas that are just bursting at the seams. Where I work in northern New Jersey, we're in kind of like the larger area of New Jersey, but honestly, compared to some other areas, specifically New York City, what we're going through is just not a big deal compared to what they're going through. One of the metrics that becomes a little more useful is this thing here. That's for 1 million population, because it really gives you like a better sense of, compared to the size of the country and the density of the country, how many cases there are. Cases per 1 million population is also useful. Again, that one's not about people dying, it's just about the number of cases. And then you can sort of compare, right? You can see how many deaths as related to the number of people affected. So, when you look at comparisons of size, so for example, let's look at US and Italy, right? Italy right now, as it stands, has roughly 2.5 times the cases, but they have a lot more than 2.5 times the deaths. So that becomes useful to compare what's happening in the U.S. compared to what's happening there. Now, in all fairness, there's a number of variables. We can't just look at this and say, oh, that's what's happening, because there's a number of variables we're not seeing. For example, Italy and Spain are like weeks ahead of us. So if you think about that, those cases that ultimately go on to die probably linger in med-surg and in the ICU for a couple of weeks. So if our death rate looks low by comparison, it's not because we're super heroic. It's probably because they are still transitioning, right? Because Italy is a couple of weeks ahead of us, the people who ultimately will be deaths in the U.S. might still be in med-surg or in the ICU. So again, consider progression of cases and how long it takes them to progress to be an important factor here. Germany, interesting. They have like one of the earliest cases in Europe. If you guys didn't follow it, somewhere in, I want to say early February, they had one case. It was a lady. She went to Germany. She had a meeting with 3 guys. One of the guys turned out to be positive. 2 others ended up being positive. This lady then flew back to China. She came from China. I didn't mention that. And they had some progression, but their development was pretty static for the most part. And I think they contained it pretty early, so you didn't really see a lot of exponential growth in Germany. But what you're seeing now is exactly that, right? It's just a significant increase in cases. As you can see, Germany's already ahead of China, at least in theory. And you wonder why, but the idea is it's probably bleed over from the European cases. So that one early case came directly from China, maybe contained, didn't really grow in any significant way. On the other hand, when cases started to leach over from Italy and other parts of Europe, Germany got the same level of endemic growth that everybody else did, right? So again, an interesting development from a country that put out numbers early in the game. Again, the first country in Europe that I knew of, at least outside of China and the Asian area. There's some others. The United Kingdom is starting to put up some significant numbers. They had this kind of bizarre, we're going to let it go through the population and develop herd immunity, like let it hit us quick kind of theory. But they've backpedaled from that. Boris Johnson, their prime minister, is now infected. I don't think that necessarily had a very, very direct impact on their decision making. But the idea here is, I don't know. They're widespread testing now, and I think there's a greater, more aggressive movement towards their National Health Service to try to contain and identify the cases. But frankly, at this point, I mean, that's 4,200 in a day is endemic growth. Those are not people coming in from the outside. That's stuff that's being transmitted domestically. So not a valid game plan anymore. Brazil's one to keep an eye on. Their growth is pretty significant. Again, their total number of cases is still fairly low. But again, like I said, I think eventually we're going to stop looking at this column and we're going to start looking at columns out here to see the density of cases. So the reason that becomes important is this thing peaks, right? And then it runs out of susceptible hosts. So what ends up happening is once a whole bunch of people had it, and a whole bunch of people, they say, is between like 60 to 80% of the population. But the idea there is once 60 to 80% of the people have it, or vaccinations, that would be just as good, but we're probably not going to get that fast enough. But once 60 to 80% of the people have it, the idea there is the virus runs out of susceptible hosts, right? The transmission drops significantly because there's just not a lot of people left who don't have it because everybody has either been contaminated or died off, right? And when you're contaminated, you develop antibodies, so you're no longer really susceptible if this is an ordinary infection. That's how we got rid of, for example, measles, right? We vaccinated everybody got immunity, and then there was no susceptible hosts left, except those half a dozen anti-vaxxer kids. That's kind of where plans like this go wrong. But again, if most people get it, the idea is that you develop a whole bunch of immunity. Of course, the question is, how many bodies does that cost you, right? And does it overwhelm your health service to the point where they can't treat people anymore? So, again, interesting to keep an eye on, but probably not the biggest resource. Somebody turned me on to this one. This is COVID19.healthcare.org. I'm sorry, COVID19.healthdata.org. It is a website that will list the resources in your particular state. So I find this kind of fascinating because what they use is modeling, like epidemiological modeling, to see where they think the spread is going to be. And they give you a peak estimate date. So today is the 2nd. Peak in New Jersey is expected to be on the 8th. Yeah, I know. But they also tell you expectations based on, again, these models of how many hospital beds you think you're going to need, how many are available, and where your shortage is, and then how many ICU beds, probably the more critical factor for our purposes, than beds that are available. That's actually more than I thought would be, and your shortage, which for us is about 1,000. And then, interestingly enough, number of ventilators needed, but it doesn't tell you how many vents there are. My guess is significantly less than that. But interesting, and they'll put this like on a chart here and a model, and they'll give you a peak of expected daily deaths, and again at the highest point where they expected deaths to be. So this is pretty interesting. You can look at it for your state if you live in the United States. There are some states that have excess beds, which is fascinating. I mean, who would have thought, right? They actually have more ICU beds than they think they're going to need based on the models. Again, we don't know how this is going to shake out for real. But, I think they've done some reasonable epidemiology here to try to figure it out. All right, like I said, I work today. What's going on locally? Some of the BLS services have bowed out. I mentioned this before, but a couple of others have basically said, hey, we cannot continue operating during this pandemic, or we simply won't respond to calls that we think have to do with COVID. Others are pitching in, mutual aid agencies, commercial operators, hospitals. There are a number of players here trying to cover the particular areas that are short, so that's definitely true and reasonable, and that's kind of how you do it, right? If somebody can't make it, you go to the next service over. Long-term care facilities are just scared stiff out here, and I'm sure it's like that everywhere. Ever since that nursing home in Washington had so many people transmitted to each other and had so many fatalities, you basically can't even get into a long-term care center now, even on a 911 call, without being screened and having a mask. So, if a resident of a long-term care center stubs their toe and the ambulance gets called, you cannot pick up that toe pain without an N95 and having your temperature taken. And I don't know that that's unreasonable, frankly. I mean, they have the most vulnerable population. Some subacutes are also not taking patients from the hospital, or at least limiting them, basically telling them, hey, you have to do 14 days in that hospital with a negative PCR before we'll take you. PCR, by the way, is the test for COVID-19. Let me see if I get this right. A polymerase chain reaction, I believe it's called. Yeah, I mean, and the other thing too is if you don't have COVID-19, do you really want to hang out in a hospital more than you have to? Because that's certainly a pretty good way of getting it, is to hang around in a medical facility. So yeah, it's tough. They're converting up here in northern New Jersey a subacute to handle the acute care hospitals load. So what they're trying to do is they're trying to take out of this larger kind of university medical center, they're trying to take out all of their non-COVID patients, bring them to this subacute for their hospital stay. And I was going to use air quotes, but they technically are temporarily licensed as an extension of the university hospital. And they're going to keep the university hospital as a COVID-specific facility. So in theory, everybody in that facility would be a COVID patient. Reasonable plan, I think, because probably more acute, I would think. So that's kind of where they're going. So I had 2 COVID patients today. One lady was pretty vigorous. I would call her reasonably minor. I think she just had a positive PCR and was not feeling well. In her case, she has some pretty advanced dementia, and she fell and couldn't really get up, and apparently had been on the floor for a couple of days. The husband was in touch with the doctor. The doctor was trying not to send her to the hospital. They finally broke and decided she would go. Ended up BLSing this one. I didn't transport the patient, but I helped the BLS get that patient squared away. 2 EMS personnel. My second patient was like pretty close to respiratory failure. In a lot of locations, they're discouraging you from doing advanced airway procedures. Out here, we're trying to minimize our contact with aerosols. This guy was pretty borderline. He wasn't quite in respiratory failure. He was still maintaining a reasonable SAT, but you could tell he needed to be tubed. He was 95, no DNR. Like, he clearly just, I don't know that his situation would have been improved. He was actually not COVID until they did a CT scan of the chest, and as described by the radiologist, he had broken, or what do they call that? Opacities, the sheared glass opacity, or whatever it's called, in the CT, which was consistent with the pneumonia that you often get with COVID-19. So they were sort of assuming from the pneumonia that he was likely to have it. He was like put on comfort care because they had a discussion with the family, and I think finally talked him into the idea. All right, 2 EMS personnel died locally. Actually both of them BLS guys. One active, but I think semi-retired. The other guy was a pretty active guy, 33 years old, again, fireman, EMT. Kind of a shame, both COVID patients. 2 physicians, one a pulmonologist from where I work, one an emergency physician from a facility nearby. Really just tragic. The ER doc, pretty young, I would say, like late 30s, early 40s maybe. A bunch of people I know are positive. These are EMS providers, full-time people who probably got contaminated at work. I mean, you never know, right? But it's the most likely event. So one thing to consider is your amount of inoculum. I don't know if you folks ever gave this any thought, but when you get a particle of virus in you, you can become infected, right? And then the virus replicates. It's basically going to duplicate itself. And when enough virus duplicates itself, it then sheds, right? You give it to other people, but also like your level of disease is going to be affected by it. And there's some data that suggests that getting a little inoculum, meaning a little bit of virus, is probably not as bad as getting just a ton of virus, right? So let's go back to this emergency doc. This guy is probably like tubing people, working up ICU patients, or at least patients who are going to the ICU, meaning very acute ones. He's likely seeing several of them at a time, meaning during a shift. So this guy is probably getting blasted with inoculum. And we could probably say the same for those young doctors in China, right? These are guys in their 30s or 40s, and gals, really mean to be sexist here. But these are people who are working in just, battlefield conditions, right? They just got more patients they know what to do with. They're overwhelmed. They're seeing a ton of patients. Sure, they're wearing PPE, but the idea there is they're just getting hammered with virus all of the time. And if that's the environment you're working in, getting blasted with a bunch of viruses at once, meaning that they duplicate exponentially faster, right? And they tend to overwhelm your system to the point where you really don't have a lot of time to react, right? So your generation of antibodies is going to be behind. So if we compare the guy who gets one particle and it slowly builds up and your body hopefully can adjust to that and create antibodies, versus the guy who gets hammered with a whole bunch of inoculum at once, and the viral count rises very, very quickly, his body may not have the ability to catch up to that and to react appropriately. So his opportunity to build up antibodies and fight it off may be lesser. And there's some data to suggest that that's a factor here in how people do. So I would urge you to consider minimizing your inoculum. So how does that work exactly? Let's find out, because I think I just went the wrong way here. Right. So you need to expose the amount of stuff in your particular environment. Many of you are probably on no aerosol generating procedures right now, so you may be prohibited from nebulizing people. It's very likely you may be prohibited from CPAPing people. And the CPAP is interesting because it generates some aerosols because it's deep in the patient's lungs, right? And they're breathing out, and there's a lot going on there. Lots of pressure maintained in there. But the other thing to consider too is you can't really easily attach an filter to a CPAP, right? Because a lot of those don't have ports that you can easily capture. They may be vented, so you can't capture everything coming out of the mask, or they just may have a port that vents out extra air all the time that you can't really see the filter on. So here, I'm showing you folks just some examples of inline filters that might help. So as you can see, here's an ambu bag attached to a filter, which I just circled. Here's your CO2 detector. Here's your ET tube. PEEP valve's up here, but it's not really relevant to this conversation. When you bag the guy, it goes in this way down the tube. When you release the bag, the patient breathes out, hits the filter, goes to the exhalation port of the ambu bag. So hopefully the air that's going into the environment of your ambulance has been filtered to some degree to trap some respiratory moisture. You see here something really similar. This is basically on a inline suction that you would see on maybe like a trach patient in a hospital. This is your filter that would hopefully capture a lot of that stuff. Even on just an ambu bag, I mean, you don't need an advanced airway. If you're bagging the guy, the air's got to come out somewhere, right? Under normal circumstances, comes back out, goes out the exhalation port. There's a little diverter here that hopefully keeps the air from coming directly out at you. But this hits the exhalation port. You can actually do this also on a nebulizer. So here's the same getup, but it's on a nebulizer device. And again, a lot of medical directors right now are discouraging nebulizers, so you may not even be doing that right now. But like you see, you can minimize the amount of inoculum floating around in your truck and hopefully indirectly leaking into your mask by controlling the spread with some of these filters. Useful. I don't know what the filter market looks like right now. I asked the head of respiratory at my hospital, and he kind of said, not great when I asked him about the supply chain. So he says, use them while you got them. But, you know, we may have to come up with a different game plan. So this is not me. I share a haircut with this guy, but that's about it. This is not me, but it's a pretty good representation of what we're all wearing in the field. So N95 mask, eye protection. These are just glasses, but I was wearing eye protection all day. And I put one of these gangly things on the outside because, again, even though I have some stuff over my eyes, this is going to minimize inoculum. I also had a gown, by the way. So in my case, it was like just a hospital gown here. Frankly, I'd rather be wearing Tyvek because I would like just a sheddable layer I can get rid of, but we don't really have any operational ability to do that just yet, and the government's sort of sitting on their hands making this recommendation. But let's just talk about the face shield for a second because it's useful, right? I mean, you're breathing in here and you've got the respiratory filter from the actual N95. But the idea here is stuff coming at you, whether it's a cough or a breath or just ambient air to some degree, gets deflected off your face shield. So this thing is protecting your eyes to a fair degree, but it's also protecting your face from getting lots of direct contact with exhalation or vent from the patient. So useful. You can shed it, right, along with your gown, and now the stuff inside, meaning your mask that you're likely reusing, by the way, and your eye protection hopefully has less stuff on it, right, less virus. So, you know, potentially a useful tool, something that you should consider using if you're not doing it now, and if it's available. So this is me. And this is me holding my favorite new toy. Okay, this thing is just awesome. It's an electrostatic sprayer. And I could not be more excited. This is like the highlight of work right now. So it's basically a giant disinfectant gun. You've probably seen some of these used in China if you've been keeping your eyes on the news. But holy cow, just the sheer joy of spraying everything in the truck with this thing is just awesome. So here's an example of me. Oh man, let me see if I can do this right here. Stand by. Let me just take that off there. Ah, there it is. Okay. So we use a bleach solution in this thing. And it just does an awesome job at coating everything. I'm sure it can spray several types of disinfectants. We use a hypochlorite mix, which is just basically a bleach powder, I guess, and then mix it up. But yeah, the gun is a little out of the frame here. Just give it a second, it'll come back in. But it just coats everything with a mix of bleach. And if you just let it dry, I don't know, maybe like 5 to 10 minutes, pretty fair chance you'll kill everything. And I'm just coating everything that I think might have touched a patient at this point. I'm hitting door handles with it, stuff that we may have touched. I'm hitting areas where I think the patient may have some respiratory moisture may have settled. And even if we don't transport people, I hit our bags with it. I mean, the only thing I don't do is spray us with it because it's probably somewhat unhealthy. But again, if you have a surface, this thing is just awesome and so much better than wipes. So the other thing that happens is, hey, you know, what ends up happening when you come home, right? Like you've been working all day, you've got your uniform on, you've got all of like your belt and your stuff, right? Whatever that stuff happens to be, whether it's maybe you have a personal radio, maybe you have an ID badge, maybe you have a pen, maybe you have a personal piece of PPE like some goggles or something, or some like safety glasses. Understand you're dragging virus into your house. It just is what it is. I mean, there's just really no avoiding this. And there's been some data on previous coronaviruses, and they did it on COV-2, which is the current coronavirus. And this New England Journal of Medicine article that I put on the bottom has COV-2, which is COVID-19's virus, living up to 72 hours, like 3 days on some surfaces, especially if those surfaces are plastic or stainless steel. I mean, they last up to 72 hours on that. And that data is pretty consistent with the coronavirus studies that have been done before on the other viruses like SARS and MERS. So imagine this, right? Imagine you're like trekking around the patient's house. You are not wearing Tyvek if you're me, right? Maybe you back up against the patient's bedspread and there's some virus on there, so now it's on your pants. You come home, right, after a day of work. You maybe sit on your couch, and I've got virus on your couch. And then, like, you touch it, and you touch your eyes, or someone in your home does that, right? So that is a potential source of transmission. So you need to give this some thought into how you're going to contain this in your own home. If you've not done anything yet, you need to really give that some thought, because you're just dragging an inoculum into your house, and it should be pretty small. But still, again, if you have an elderly relative or an immunocompromised relative, then you've got some problems. So you need to think about your uniforms. You need to think about the stuff that you bring back with you. And you need to think about your body, right? Your hair, in my case, not a big deal, but my skull, I guess. You need to get that stuff off of you. So if you don't have a routine, you need to give some thought to a routine. So I just wanted to show you mine real quick. This is what happens when I get home. My door is somewhere to the left here. So when I walk in, I just basically start peeling away things that I don't necessarily need. So my watch, in this case, my stethoscope. I've never cleaned my stethoscope more in my life than I do now. This is just, again, a pair of goggles I usually wear. It's my wallet, which I've probably taken out of my pocket at least once or twice that day. My ID badge, and just a belt that I carry my junk in. So I put all of this stuff on my counter, and then this bottle of isopropyl lives there, which, by the way, has been shown pretty effective against COVID-19. And I just bathe everything in it. I just sit there and I spray every surface. And the nice thing about alcohol is it dries pretty cleanly. So the hypochlorite gun that I showed you earlier, that thing leaves streaks. So if you do it on Windows or a touchpad or something, it tends to make it pretty messy. But isopropyl dries really, really clean. So if you just spray everything, there's a fair chance you're going to get the virus pretty effectively, especially if you're thorough with the spraying. Next, step 2, I keep this little hamper above my door, and every piece of my uniform goes in there. So basically, my job shirt, if I'm wearing one, the undershirt, the pants, my boots come off here, and I spray those with isopropyl also. The one thing that's a little hard to decon is my jacket. The weather's getting nicer, so I may not have to wear it very much longer, but the jackets, when you throw them in the wash, they have a tendency of losing their like water repellent characteristics. So what ends up happening is I usually just spray the alcohol over the jacket, and I just kind of isolate it for a while if I can, so nobody touches it. But the next step is I make a pretty pathetic semi-naked run to the shower, and I end up scrubbing myself down. And when I come out of the shower, I'm reasonably comfortable that I'm virus-free at that point, because it's not supposed to be able to live through soap. So it really is a consideration you guys have to have when you're coming home, because I'm sure nobody here wants to make a relative sick or just get sick afterwards. It'd be such a bummer if you do battle with COVID for a 12-hour shift, and you come home and you pick some up off your uniform, you touch your eye, and you make yourself ill, right? That's a shame. So conclusions for today, you got to take some precautions, and a little overlap and redundancy is probably good, right? If you have the goggles and then you put a face shield over it, that's probably fine. A little extra doesn't hurt as long as you have the PPE. Same thing with gloves, right? Using 2 pairs probably fine as long as the supply is adequate. And just give yourself some thought about a decontamination routine at home. You absolutely should not be coming home and just plopping down on the sofa or going right to bed. without some kind of cleanup, because this thing can live on surfaces for 3 days, and under some circumstances, and nobody needs that. So hope you enjoyed it. Hope it's been useful. Stay safe out there.